immunotherapies and their targeted therapies, that we sometimes forget some basic things what we could do better for the patients. And thank you, organizers, thank you, sponsors, for this session, and thank you, chairperson, for. And in the next 15 to 20 minutes, maybe 25 minutes, which I've got, I will try to give a comprehensive outlook on how where we can do better for our patients of cancer, and what vaccines at least we should be thinking of when we do the chemotherapy next time, and what patient profile would benefit from vaccination. So if you look at it, the cancer patients have a higher risk of getting more infections. They are more susceptible to vaccine preventable infections. And here I mean there are vaccines which could be which are already available in the market. And if you look at it, there is a good amount of mortality, let's say like pneumococcus, which we have a good mortality in the multiple myeloma group of patients, hemat malignancies, and patients receiving high dose therapies. And the malignancy itself and or the immunosuppressive therapies which we give also increases the risk of these types of infection, to name so, where the pneumococcus, influenza, and hepatitis B. And we need to know whom to vaccinate, when to vaccinate, and what to vaccinate. That's something we need to know, the proper timing and the best patient profile that we need to select so that this patient really benefits. And is there a data or a recommendation backing what I'm going to speak? So now let's go to the next part of it. The types of vaccine, it's very basic. All of us know from our MBBS days. We look at the live attenuated vaccines. That would be tuberculosis, oral polio vaccine, measles, rota, and the yellow fever. The inactivated and vaccines, that are the pertussis or the inactivated polio virus. We have the purified antigen. We also have the toxoids. More popular is the tetanus and also the diphtheria toxoids. So these are the vaccines which I'm not going to go into details of it, but some of the vaccines could be contraindicated when we're giving active chemotherapy, because if they are a live vaccine, I would be very skeptical, and a lot of us do not give these vaccines during the phase of chemotherapy because of the immunosuppressive stage, and they could actually do more harm than good. So coming to the pneumococcal vaccines, the global recommendation of the immunocompromised cancer patients, if you look at the NCCN, and we all follow NCCN for all our oncology patients. And if you look at it in 2013 itself, and the ESMO again 2013 recommended pneumococcal vaccination for patients, especially those who are undergone splenectomy and those who are undergoing high dose stem cell transplant, the stem cell transplant patient, and other high dose therapy having a immunosuppressive effect. If you look at the Center for the Disease Control and Prevention, they also have recommended, especially the pneumococcal vaccines, the two types which will come in a bit. In adults, are the same patient segment, hemat malignancies, post-splenectomy, patients who are eligible and receive high-dose therapy. Even the Germans and the American Society of Blood and Marrow Transplant recommendation also look at the use of pneumococcal vaccine in the high-risk subset, especially the hemat malignancies. So if you have a right from a patient, you have two varieties of vaccines. Actually, what you're looking at, the PCV13, that is, and we look at the polysaccharide vaccine, that is the PSSV23. And if you look at this, we normally in America and the Western countries, all the child below 10 years are at least vaccinated with the single dose of the PCV13 vaccine. So normally they start off with the polysaccharide vaccine. But if you look at India, we are very much behind even on the vaccination part. Some people have started vaccinating the PCV13 in the childhood below the eligible age right now, but we do not have a herd immunity as such. So if you have a dose of PCV13 that is there, and that is over the age of 19, you would go for a polysaccharide vaccine. The two doses actually, the first dose would come after 8 weeks or more, at least of 8 weeks of gap between the PCV and the polysaccharide vaccine, the conjugate and the polysaccharide vaccines. And the second dose is given at least around 5 years at a difference of the first dose of the polysaccharide vaccine. Beyond 65, you just need one dose of the polysaccharide vaccine. Actually, And this is how normally we would look at how to vaccinate this patient, and the patient profile for us has been already described. So, if someone has, for some reason, been vaccinated with a polysaccharide variant of 23 before, then you would at least give a gap of 1 year before you vaccinate with the PCV13. So, this is something that we need to remember. This is how the vaccinations normally goes through, and the recommendation does come to vaccinate in the right patients, immunocompromised, eligible for the hemat malignancy, especially, or high dose or stem cell transplant or splenectomy in the age of 19 to 64. If I go ahead, again, this is what I spoke of. In India, the difference is that we do not have a vaccination program robust that includes this into it. There are people who are doing it right now, but we still have not attained the herd immunity in the Western or US that is there. That's why they look at it very differently. And because everyone is vaccinated with a PCV13 uh, within the first 10 years or in the childhood, they would just go ahead and do the polysaccharide one. So this is where I would look at it. All the guidelines, the ITSA and the ACIP guidelines do look at and recommend this vaccine. And apart from that, if you look at it, these two guidelines also recommend influenza vaccines. This is again a very important, and we also have been looking at influenza very, very carefully after the COVID outbreak. A lot of us, the discussion has happened on this. But if you look at it, we have not been vaccinating on the seasonal flu vaccines quite often. And these there are international guidelines which do tell us that patient with immunocompromised condition, including those not limited to patient congenital or acquired immunodeficiency states, patients specifically with asplenia or hyposplenic functions, or patients who are going to immunocompromised chemotherapies should be receiving an influenza vaccine, and that is as per it. And most of the Western worlds do practice this. But what when to do it? Either it is given 2 weeks before we start the chemotherapy, or in between also we can do, but the ideal time would be 2 weeks prior to start of the chemotherapy. But if there is a patient on immune checkpoint inhibitors, the recommendation is quite safe to give this during the therapy point of view. But important is, if someone is on a rituximab type of therapy, probably patients who have been immunocompromised or is having something as a rituximab based chemotherapy, then you would like to give a gap of 6 months at least before you should be giving it, because the antibody generation would be hampered. So that is something I would like to make a comment here. And live influenza vaccine should not be given. Is the data to that? And if you look into this carefully, this is the last data from the Ontario, Canada, and this looked at two things. If you look at the first one, it is vaccinated versus non-vaccinated. So patients who are testing for positive for influenza, so if the patient has been vaccinated, they have lesser chances of getting the infection than those who are non-vaccinated, and it was statistically significant. But if you look at the quantum of benefit, the vaccine efficacy is maximum in the solid tumor patients. Patients of solid tumor due for chemotherapy or intensive chemotherapy, they do benefit the most. The hemat malignancy, in contrast, as per this study, the quantum of benefit was much lesser than what a patient of solid tumor would do and would get and receiving active chemotherapy. That's something that has come up from the large population-based study. So, look, moving gears to the DPT, the tetanus, diphtheria, pertussis, it is just that you can use this vaccine. This is a vaccine to be given to the immunocompromised. I would not think there's a high-level evidence, but yes, there is a data that you may give this vaccine in this subset of patients. Hepatitis B is something which we need to be more careful. I have had one or two patients, which I have told in my previous talk also, which I had to land up with hepatic failure because of this point of I just neglected this part of the schedule of the therapy before I started therapy. So every patient, especially a lot of these patients who are on myeloma patients, who are on the bortezomib based therapy or lenalidomide based therapy, we would like to vaccinate them with hepatitis B if not done, and the schedule is well known. So we and all of us have been vaccinated, but we have to see that do we have enough antibodies against this. If not, the booster dose would be required. So that is again something that patients with HIV infection or someone who's taking a specific type of therapy would be definite that we have this vaccination done. For the meningococcal only if you are traveling to particular things. It is nothing that you need to do it for everyone. Splenectomized patient is definite. That's the other thing. But otherwise, for international travelers going to countries like Africa, which is a meningitis belt, you might be interested in doing that. But I don't think, at least in most of the India, we see this patient profile. That would be something for the metros. Few of these African patients, when they treat on the international programs, that might be something for them to remember, that probably this is a vaccine they have to keep in mind and should be given. And during these patients, when they're receiving immunosuppressive therapies, the only contraindication, if there's any allergy to any component of the vaccine, then it is not to be given. The human papillomavirus is something which I feel has caught interest only after it was related and the vaccine was there for the prevention of the cervical cancer. Till then, we were not much there. The vaccines were not there. But to my point, as per the Indian scenario, from 9 years to 24, 25 years is the age group which I would like to catch and vaccinate them. The girl child is the interest topic or subject of my interest here. And if given a choice, I would like to do to a girl child pre-college, probably in the school. The high school age is the age where one should be doing the human papillomavirus. I would not take away the cervical screening out of the picture, because that is something that needs to be there, because it protects us from the two major subtypes, the 16 and the 18. But if it should be given, there is data for the anal cancer and the human papillomavirus vaccine. But I think at this point in India, the interest is on cervical cancer, because the quarter of the load of the cervical cancer is from our country. And I think it is high time that we do vaccinate the eligible group who can afford it at this point of time, because this does contribute to decreasing the incidence probably by tune of 75%. So 75%, if the vaccine is very effective and is nearly 100% effective against these two subtypes. That's something which I wanted to speak. Hepatitis A, I'm not sure I would be changing my practice and doing this. But if someone is interested and someone has a patient, probably we in India, our water hygiene is not that good. The food hygiene is still found wanted in a lot of the things. If you are doing for a patient intensive therapy, you could do that if there are two doses, one dose of hepatitis A and then a booster dose at least 6 to 36 months or 6 months to 3 years. You can do a booster dose, but that is something I don't think is very popular and very few of us do that. Varicella, I would not be very sure. I would vaccinate such a thing or tell in the. What I normally do is I do give prophylaxis of acyclovir. But if someone has developed in the previous cycles, definitely. Otherwise, for my myeloma patient and some of my immunosuppressive patients, I do give it the acyclovir as a prophylaxis to not have this. But I have seen around there's data that 8% to 10% of the breast cancer patient do develop herpes zoster, and if they have developed in a particular cycle, then it would be very much prudent for us to give this acyclovir. I am not sure of the vaccination part of it, but definitely acyclovir is something I'd be very, very closely watching and giving it. MMR, nothing much to speak. In the childhood, if it is during chemotherapy, not to give. Post 3 to 6 months of completion of chemotherapy, you should be giving this. Uh, Cholera, again, skipping this, but telling that typhoid, you would be avoiding this because it's a live vaccine. The oral vaccine should not be there and should not be used during active treatment and during the immunocompromised patient subset. So do have guidelines for that. I spoke of nearly most of the important vaccines, but if you look at the guidelines, the German, the across the world, I picked up one guideline. But if you go across guidelines, as the NCCN, the ESMO, the German, the American transplant group, they looked at I'm looking at the German part of it. They looked at this evidence. Do you have enough evidence to support this? If I cut the whole thing short, and the level of evidence is very high, the strength is for recommendation is the most strong. The quality of evidence, one is the highest form of evidence. If we look at it, these are the three vaccines which I looked very, very carefully: the pneumococcal, the influenza, and the hepatitis B. There is data for pertussis, but I think this three is where I will put my money on. And I would like for the right eligible patient, the pneumococcal vaccine, the influenza vaccine, and the hepatitis B vaccine is something which I'll be very, very careful in vaccinating my patient before I start the treatment for most of the patients who are hemat malignancies or receiving high dose therapy. Rituximab is a peculiar problem. And if you look at the stem cell transplant, especially the auto stem cell and the rituximab, because of the way it works and puts the B cell function down because it's an inhibitor for the B cells, it defer vaccination for 6 months or use vaccinate something below 2 to 3 weeks prior to initiation of treatment. If not, do not vaccinate during giving rituximab because your motive will not be achieved. You would not be achieving the level of antibodies what you would like to have. So you would like to defer vaccination during active treatment with rituximab. For auto stem cell transplant, live attenuated vaccines are avoided and avoided for 2 years. The data is as per the vaccine type for 6 months to 2 years. Our MMR, yellow fever, varicella, to be no others like influenza vaccine, you could vaccinate after 3 to 6 months, but most likely the recommendation is you do it after around 1 to 2 years. And this is what the recommendation is. If you look at it, except for the influenza and the pneumococcal vaccines, which you may do it in 3 to 6 months post stem cell transplant, most of the things are beyond 1 to 2 years. And that's something we need to remember. This is a doctors who practice auto stem cell transplant are very as medical oncologists should be also aware of the same. If I look at the child pediatric age group, just 2 slides here. During chemotherapy, all live vaccines are really a big no. If you look at the BCG, it's not recommended. Contact vaccination is not discouraged. But one thing is there, and which is definitely discouraged, is the oral polio vaccine. If the contact, you have a sibling who's eligible and you have a patient in the house who is going for a leukemia, we would advise as doctors that the contact vaccination for the oral polio virus sorry, excuse me, it should be something that you would not be okay. But other than that, you do not want to give anything that is live vaccines is contraindicated. If you want to give, you at least wait 3 to 6 months post the completion of the therapy. And that's what the recommendation is. For the non-live, again for the pediatric age group, if you look at it, it's not recommended. Mostly all the vaccines are not recommended during therapy, but you would vaccinate the unimmunized children after 3 to 6 months of the completion of the therapy. And for the contacts for the pediatrics, I just wanted to have this last slide on pediatrics. For siblings, the live vaccines is to be avoided. Varicella vaccines is encouraged. For parents also, inactivated influenza vaccines is strongly recommended. Varicella vaccine is also encouraged in the unimmunized patient. The last 2-3 slides on the COVID-19 vaccine. All of us have been vaccinated, but we still have a lot of our patients still are not completely vaccinated for 2 doses. And some of them have not vaccinated themselves because of a lot of reasons which is beyond the scope of this lecture. But I would like to end off my talk on this 3 or 4 slides. And we know the vaccines. I'm not going to talk on the vaccines. But what are my take-home message for the COVID cancer patients? Cancer patients are at more risk to have COVID infection. We have data to that aspect. We spoke about it the whole of last year. The outcome is poorer as compared to others. We had a debate on this. There are data to tell it does not much matter with COVID and cancer. There were data to it that yes, it did matter. But one thing is sure that if someone has a rituximab-based chemotherapy with COVID, the outcome was probably they had the worst outcome among all the cancer patients. Vaccination is an important effective strategy to reduce the chances of infection and reduce the severity. And the second slide take home would be ideally vaccinate before initiating treatment. That's the ideal scenario, but that's normally not possible because you vaccinate, wait for 7 days, people would not be very okay. They want the therapies in very fast. But can you vaccinate during chemotherapy? Yes, you can. Usually the days before the next cycle is the most important when the counts have recovered. And you can vaccinate the patient even on the day of therapy, but at least a gap is okay. But someone wants to vaccinate on day of therapy, I don't think that's a contraindication. They can do that. Avoid during neutropenia. It's not that it's contraindicated, but you should avoid during neutropenia. That's why probably before the next cycle is due is the best time to vaccinate. And if you look at it, patient on lymphocyte depleting therapies, you wait till the recovery of lymphocyte is beyond the 1,000 per cubic mm mark. For rituximab, as I told you, vaccinate 14 days prior to initiation, or do not vaccinate during the therapy study. Wait till 6 months post completion of the last dose of rituximab. At least what they've told is 6 months, but I would always recommend, and even Dr. Hemant sir is there. We have discussed a lot about it. I think the 6 months is a good time by the time you have that B cell activation up there. Acute leukemias, don't delay the induction and avoid during the intensive therapy because of the incidence of the neutropenia, not a contraindication, but you should avoid it. The stem cell transplant, wait for 3 months from the stem cell. 3 to 6 months is a time where you could vaccinate your patients with COVID vaccine post 3 to 6 months. The last slide, the pediatric population can undertake the other vaccines which are there on schedule as per the criteria, as per the guidelines set by the government, the timelines, in addition to the COVID, once it is there. But it is still not approved, but in the right frame, when the approval comes, it's going to come very, very fast. We would be looking at this problem also, and they can be vaccinated. The complete scheduled vaccination is important to achieve adequate protection. Cancer patient, this is again something that is very, very clear. Single dose does protect, but the amount of level of protection is much lesser than a dual vaccination. And one more data that has come, and especially with lung cancer patients, it was there. The patients with cancer probably had to be vaccinated a little early, and there was data to reflect that 3 weeks between two doses of vaccination did produce more benefit than a longer duration. The way the vaccination schedule is for Covishield is 4 to 6 months, but there is data as per science that the cancer patient, shorter gap between two doses is probably more helpful in achieving more protection for COVID. On follow-up, to be treated as general patients. So my key message would be, compared with the general population, patients with cancer in general are more susceptible to vaccine preventable infections. That's point number one. Many of the infections can be prevented by vaccination. Most important is the proper timing of immunization with cancer treatment, because no one wants to delay it. So there is the data that you can, ideally scenario is before you start, specifically looking at 2 weeks time before you start is the key to achieving a vaccine protection. But I think you can, and in more lot of the vaccines can be given in between the therapies. Adults who need vaccination, and that's what we forget many times, to boost the efficacy of childhood vaccines and aid immunity in newer comorbidities and afford protection when immunity is suppressed due to acquired illness. Specifically, this is holds good for three settings if I can talk: the hemat malignancies, myelomas, high dose therapies, and more intensive therapies, even when we do for our solid tumors. A number of guidelines have strategized recommendation for vaccinating the patient with cancer, and I think when we talk so much for a marginal benefit and spending lakhs of money, I find this, if there is a schedule and there is a way that before chemotherapy I want to do a CBC, LFT, RFT, I think before you start the first dose of chemotherapy in a specific subgroup of patient, 3 or 4 vaccination should be made mandatory by all of us, because I think then we can save a lot of lives. Here I stop and give back the podium to Dr. Hemant sir for his last comments on this.
Thank you
Sahoo
very
sir,
much. Thank you very
Yeah.
much, PP. Excellent, excellent talk. And then again, in the interest of sticking to time, like the organizers will permit us not to do any questions, but all the
no, no, sir,
speakers
we
are
can have. I
requested.
actually wanted to ask one question.
Can you do it on the chat box? We'll
Yeah, okay,
request
okay,
Dr.
okay,
Sahu to please be around, and he's
okay.
very proficient in typing. He'll type his answer on the chat box. So again, we move on, and may I request all the people who are attending this webinar to put their questions on the chat box, and may I request all the speakers to please try and answer those questions on the chat box right away, so that we can conclude all the questions and answers in this session only. So